It's 8:30 and we'll call today's March 20th meeting of the Central District Health Board to order. Corey's taken a virtual role. We will approve the agenda. If there aren't any changes, but we'll approve the agenda as presented. Anything? Okay, agenda is approved. Similarly, without objection, we'll approve the minutes from last meeting unless anyone has any concerns or changes. Seeing none, we'll go with the minutes as presented. Any public comments? It does not look like we have anybody available to testify. Is anyone, I mean, we did get a couple public comments. Do we want to discuss at all? Public comments that came in. Don't talk as much. Good. All right. And then on to reviewing of the fiscal report. Conan is up this morning.
Thank you. Good morning, Dr. Birch, Chairman, Vice Chair Tucker, Board Member, Director Duke, and guests. My name is Conan Chu. I'm the Financial Support Manager of Central District Health. I'm here to present the budget to actuals today. Look at the screen or page in front of you. We are 2/3 of the year, fiscal year, so roughly we should be at 66.67% of time elapsed. As you can see from the budget from the last report, we did update the budget based on the budget revision that you approved last meeting. So those have changed and updated. So going over the revenues, we're at 69% of where we are, or where we expect to be for fees. Again, that's seeing more fees coming in. On the contract side, we're at 64%. That's close to where we expect it to be in total. And then the other category is basically, it's a lot of that's from the open settlement funds, and usually those come in sporadically. So hopefully we'll be seeing some more before the end of the fiscal year. And excuse me for my cough. I'm at the tail end of being having a cold. So in total, based on the fees, contracts, and other revenue, we're at 63%, close to where we expect to be around this time of the year. However, if we included the county contributions and interest, as you see, we're way ahead of where we're expected to be at 73%. On the expenditure side of things, for personnel, we're at 65.33%. Is exactly where we expect to be, very close to this time of the year. On operating, again, we're at 63%. Again, we're very close to where we're at for the year. Capital, again, we're close to where we expect to be at 65%. Then trustee and benefit, we're a little behind on that. However, in talking with staff, we are making sure that our subcontract or subgrantees are billing us before the end of the fiscal year, so we should see that reduce. So in total, we're at 63% of expenditures, so we're very close to where we expect to be. And if we look at between revenue versus expenditures, there's a 10% gap again. Main reason again, as you can see, the county contribution came in at 98%, so that's why we're ahead of where we expect to be. Next screen, please. I'm sorry, did anyone have questions on that page? On the left-hand side, you see revenues. based on the 3 years, this fiscal year, as you see, we're ahead of 24 and 25 for both areas for community environmental health and for family clinic services. Excuse me, Ken. And then when you look at contracts, we're a little behind where we are. However, that's expected because we saw a reduction of the number of contracts we're receiving and the amount of the contracts that we're receiving. So fees, we're looking at 3.5 ahead of time and then 3.9 below where we're expected. And then on the expenditure side, on the right-hand side, in personnel. And again, personnel, the percentage is a little different. Instead of 66.67%, that's because we look at it by number of payrolls versus number of months. We get paid every 2 weeks, so there's 26 pay periods. So that's how we account for that little difference. And then as you can see, personnel again, versus the other page, the difference is the number of pay periods. So we're under 5.6%. Same thing in operating, we're under by 5.4%. Trustee and benefit, again, as you saw from the other page, we're at 31.5%. Again, knowing that we are having our subcontractor or subgrantees making sure that they bill us before the end of the fiscal year. And then for capital, basically, we're very, very close to where we expect it to be. Are there any questions on this condition? There, the final page. The cash balance, currently at the end of February, we were carrying close to $12.6 million with special projects. And again, we had some revisions to this list, and it was approved by the board. So the numbers again is a little different. Right now, we have an unspent balance of $1.4 million. Right now, with the capital improvements, that also includes the bathroom. Basically, on Wednesday, we have about 12 vendors coming in, so we are starting that process and hopefully getting those bids in, and hopefully we can get the vendor coming in and please get a lot of that done this fiscal year. And then as you can see, some of these we've already spent. For the Acela one, right now it looks like we have 131,000, almost 132,000. We did contact the vendor to make sure they bill us. So we did receive an invoice for over $70,000 that was just paid early this month. So it'll be reflected a smaller balance in the next report.
What vendor was that?
Acela, it's the
Okay. For apartment house.
So, in going through all that, like I said, we have a cash balance of 12.5 million. We have a remaining balance of our special projects of 1.4 from 1.5. Then some of the things that we set aside, for instance, the payroll reserve funds for that 27th pay period in FY28, and then the operational reserve fund, and then the capital. That brings it down to 6.9 million, and then we have some restricted funds, including Millennium Fund, Opiate Settlement Fund, and home visiting. So that was 3.8 million. So right now we have a good cash balance to use up through the fiscal year of $1.8 million. Questions?
Can you remind me how close our reserve for the 27th pay period is now compared to what we will need?
So right now, we took a look at it, knowing also during the carryover that we were going to fully fund that through the FY 28 27th pay period. So right now, that 498,300 is our estimated amount that would cost us extra for FY 28. So we are now supposedly fully funded for
We're there.
Mr. Chair, I did have a question on you said the capital improvement expansion, the bathroom remodel is in that one, or it's in the capital continue?
I'm sorry, it's capital continue, I'm sorry. Yeah,
Okay, perfect. Just making sure that.
yeah, the others, they're in process and hopefully getting bids in and hopefully completed before the end of the fiscal year.
Any other questions?
So I know Conan doesn't get much airtime here, and just wanted to recognize him for all his work to, as the heartbeat of the organization, the money. And he does a really fabulous job, and him and his team, and keeping us in line. And I've always appreciated his willingness to help me with questions for the second, third, sometimes the fourth time. He's always got to keep that. And just really knows what he's doing. And so I have great confidence in him and appreciate all he does. Budget time, and that's going to be our next point of discussion, will be the budget that he'll be preparing. Of course, working with Laurel, his supervisor, and then all of our leaders here to put a budget together to present to you on April 10th. So, yeah.
Thank you.
Very good. Thanks for filling in this morning.
Yeah.
Get better.
Yeah.
Well, as Russ said, the next thing we'll be discussing is the budget guidance. So we will, Russ.
Okay, thank you. So what we do at this meeting is I'll just share with you generally what I would like to do, and then you can say proceed or make some adjustments to that. And what we're looking for is some structure around the budget that I'll bring to you for your approval on April 10th. That, once you approve it, will take to the budget committee. I'll talk about that later in the agenda on May 8th. That'll be the Board of Commissioners. It's called the Budget Committee, and it's the chair or their designee from each of our 4 counties will vote on the budget, and that budget will begin on July 1. So for this year, for most years, I guess, except for the recession years like 08, I think by 09 and 2010, we received level funding from our counties. We didn't ask for an increase, of course, because property taxes, everybody, the economy was struggling. And this year, what we're seeing, and I'm sure you're seeing and hearing about it, is the state cuts that are occurring. And that, fortunately, has not impacted us much, but it has. And I'll give a couple of examples of that. But those of you who were on the board before House Bill 316 passed in 2021, the districts statewide were getting a little over $10 million in state general funds. So I can't tell you how thankful I am that we moved. I don't know how thankful the counties are. That we moved over to having the counties cover that cost. And I know there was negotiations in the medical indigent fund, county indigent fund, and things like that that would help fund public health. That has allowed us, that has spared us from cuts that are occurring to state organizations and state services and things like that. So it did increase the county share fairly to our budget. And so I'm definitely mindful of that. The two bigger hits, if you want to call it that, we've taken is in Medicaid. So that's like for our healthcare services. And after a long process, we finally got our home visiting, certain programs supported by Medicaid, and then made some adjustments to that so that all the visits with Medicaid families would be covered. Now, when I say it's covered, those of you who work in healthcare know they give you a little bit of money, few pennies toward the cost of providing healthcare or home visiting services. So, but that was cut by 4%. I don't know if there'll be more cuts later this year or not. And then the home visiting budget, which was one of the two priorities we had, sent a letter under the signature of Dr. Birch and myself, was home visiting funding. It's $1 million of state general fund that was distributed out to the health districts. So we'll lose, we're likely, they haven't voted on the final budget yet for health and human services, but we'll lose about $173,000 out of that. So, and that's, you know, I know the board has been really strong supporters of our home visiting, parents as teachers, nurse family partnership. So it's a little discouraging that we're seeing that cut, and we worked really hard. I was, you know, credit to Senator Wintrow. She really advocated for it, believes in it. She was involved with Senator Abby Lee and some others getting that money in the first place. And then remember that as being a executive council trustee member. And so health and welfare, even though it's pass through money, they use that as part of their cut. So they cut it completely. Their 4% cut resulted in a 100% cut to us for the general fund we receive for home visiting. You tell them a little frustrating. So there's that. And then there's some other funding changes like Conan talked about that we have that, you know, contracts that increase or decrease. Most of them stay level if they're continuing contracts. We don't get increases to cover added costs. So as our salaries go up or operating costs go up, the areas where the board can influence and the counties is number one is fees. So as our costs go up, this board would approve fees, which we'll be doing at the May meeting, talking about both from environmental health and clinic. But the thing with that is on the clinic side, you can raise your fees, but where a large percent of our staff patients are sliding fee scale, it doesn't really generate much more in a way of revenue. On the environmental health side, we have one big program, which is the food establishment program. Those fees are set in Idaho code. So the board has no influence over those. And once those fees are set, again, as years go by, it's going to erode the revenue coming in. You might be getting the same amount and your costs go up, so it's not keeping pace. That's something that we have worked on and wanted to change in the legislature to pass that authority on to local boards of health, so you can set the fees like you do for everything else that we do, both in environmental health and clinic. So, but I think the lobbying industries has some influence over those fees, has a strong enough hold that I don't know. Any of you might have a comment to make about it. I think it felt like an impossible task.
Yes. Yes.
So I guess that's all I need to say about that. So what I would like to do this year is to ask again our counties for a 3% increase. So that's about 35% of our overall budget, and we're having to figure out how to make that work for most of the other areas that stay level, like the contracts. The 3% increase from the counties is, like I said, it's what we've done every year since I started in 2005, except for the 2 recession years. And we've always had good support from our counties to do that. What that'll allow us to do is provide salary increases for our staff. That's the big one. That's about 70+% of our budget is personnel. And with that, we don't know exactly what it's going to look like. And Conan, I don't know if we'll have better intel by the time we meet again in April, but the health insurance premiums are going up significantly. Can you share that number? You shared it the other day, and it's shocking, actually.
Right, so it's projected to cost $17,770 in FY '27 from $14,100 $30, I believe, per employee.
So that's a cost to the agency, and we're on a state plan, so at least in theory, we should be getting pretty good rates for the insurance that we're buying for our staff, because we're part of a massive risk pool. So there's that. That's part of my reason, besides everything else I talked about for my preference to do a 3% increase from the counties, is as we give pay increases for our staff, so we have a better intel on what it's going to like for the agency cost for health insurance, but the premiums are going to go up for our staff also. So at minimum, like a starting point, I would want to cover that for them so that they're not losing ground right out of the gate, and then do some cost of living and merit-based increases on top of that. I don't have an exact number in mind yet, because we'll see how this plays out with, I guess if you give us if you support the 3%, the county support 3%, then we'll build that into a proposal that I'll bring to you in a couple weeks. So it could be worse. And everybody's being impacted by this as far as like the health insurance premiums. If you employ state employees or district employees, you're going to pay. And the other part of it is whether an employee takes that insurance or not, you pay. So basically, if they have let's say they have a spouse and they're on their health insurance, military insurance, we still have to pay for every FTE we have. That's a significant cost. Okay, well, that's my presentation. So what I would ask is for the board support to request a 3% overall increase from our counties to start on July 1. And with that, I'll build in a compensation plan. I'm certain it's not going to be like we've done in years past, but I'm hopeful we can at least give some increase in pay for employees, again, to cover health insurance and cost of living, and at least a small merit increase.
I might suggest that given the numbers on health insurance increases and stuff, not only is that a cost, a financial cost to the district, but I think it's kind of reflective of the cost we're paying now for not having lifestyle and scientific driven healthcare policies for the last few decades. And now I think we're paying the piper for not addressing that properly. We have industry driven healthcare policies and things where get herself a whole.
Comment on that. Most people don't understand on health insurance, since it's a monopolistic system that's set up and under ACA. The only way health insurance companies make money, they're capped at 15% profit. So the way they make money is by raising their premiums consistently and continuously. So until that changes at the federal level, society-wide, we're going to continue to see that, because they get to dictate their profit margin by saying, oh gosh, expenses are going up. Well, we're going to raise premiums. And then now their profit margin always stays at 15%, but the individual citizen unfortunately pays the price. So we're victims of a federalized rule on that. And to Russ's point, we do want to keep the employees caught up in terms of that unfortunate inflationary increase that we're seeing. But until it changes at the federal level, and I agree, yeah, America needs to be healthier, sure, but it's kind of almost an industry cartel at this point.
Well, Idaho is one of very few states that precludes disclosure of insurance company highly compensated individual pay. We don't get to see how our tax money is being spent on the compensation of those executives, whereas in the surrounding states, they do. And with hundreds and hundreds of millions of dollars in taxpayer money being funneled into these insurance companies with premium subsidies and stuff, Idaho specifically precludes transparency on how those public resources are being invested at the company level. And the other interesting thing that adds to the profit margin of the insurance companies is the reduction in payer reimbursement. So they'll raise the premiums, reduce the provider compensation, and ostensibly bonus their executives for such a bottom line. And then you start to see that ripple effect through the premium increases in the private sector, the public sector, etc. And I tried to make that change a few years ago, but was summarily beaten back on that transparency issue. But we might have another chance at that again.
But at the end of the day, we need to compensate for the shortfall that House points out. How do the counties feel? I mean, they're getting pinched too, but really, we need that. Yeah, I know, right?
One of our commissioners be open to promotion.
Would you like to come now?
We should make. To agree to it. It's definitely frustrating. We see increases. We actually, in Elmore County, year before last, we actually did not have an increase for our health insurance. I don't know what our HR director did, or but then it doubled the increase for the following year. So you see it eventually, so I think that's common amongst everything. I know me personally, I had to make an appointment through one of the major health systems in Idaho. And just for a simple thing, it took me 3 appointments to get the actual thing done. I'm like, it takes forever to get an appointment. This is why you can't get an appointment. You're making me make 3 and that might be it because the providers aren't getting as much as they used to. So anyway, I go out, but.
Malaligned incentives.
Well, Mr. Chair, it discourages me, the massive real estate holdings that the insurance companies are obtaining. Massive.
Well, there might have been counties that have tried to have conversations about that, but it's again, modifications and those conversations meet headwinds.
Like what you said about you pay for the FTEs, even if they don't take the insurance. What does that mean?
Mr. Chair. So the way the state health insurance is set up through the Department of Administration, it's based on the number of employees you have and whether or not they take insurance, meaning they obviously wouldn't have to pay their premium, but we have to pay the premium based on FTEs, not based on the number of employees. We don't have, honestly, a lot of employees who don't get the insurance, but it's a handful that would get it through other means, or like I said, the military or spouses that may have better plans or cheaper plans. So yeah, we will pay that $17,000 for an employee who does not get health insurance through Central District Health. So that's the way, it's not just us, it's all the health districts and all the state agencies. So I'm not sure why it's structured that way.
That doesn't make any sense.
Yeah, that'd probably be a Conan question. I don't know, why they do it that way.
Well, like you said, it's how everything's structured. However, when I was at Fish and Game, because number one, it's a statute, I think. So when I was at Fish and Game, there was another statute, diversion of funds. So because our employees were not benefiting through that, so we contacted U.S. Fish and Wildlife Service, and they helped us fight against this statute. So then Fish and Game basically is on a separate fee schedule, or a different fee getting into health insurance.
So how many individuals in the district, health district, are in that category? Or were you speaking in the state and the bigger pool?
So
handful, like you said, a handful.
in our district,
A
I'm
handful.
sure it's more than, like statewide, if you looked at all the big state agencies. And in fact, that'd be a good, I can get that information to you. Gary would probably have it and he'll know. And I think the problem is when they set the premiums, people are on insurance and a life change, and then they may join our insurance plan, others may drop off. So it's not like set at the beginning of the year. And that's exactly, if we hire new staff, they'll be added to that pool. But I can get that for you, how many of our approximately 150 employees are not accepting health insurance, not taking advantage of our health insurance.
Just wasn't sure I heard you right.
Yeah, it's kind of, I don't know, it's set up like workers' compensation, like if we had a bunch of claims because we're part of a risk pool, our premiums aren't gonna go up. Because I guess it's distributed among, thousands of individual employees and however many state agencies there are. And I think health insurance is kind of the same, although clearly it's going up because the costs are, well, Dr. Cole already talked about why that's happening. But that's when you said that number, I feel like it was 12 to 13,000 for quite a few years. It didn't go up, and then we saw that drastic increase this last year. Part of it, I'll say, I don't even know that you tried the weight loss drug that was super expensive. So there was a lot of it, then they're not covering that anymore. Do you know what I'm talking about?
Was it big job?
Yeah. So what ended up happening, they had a lot of, my understanding, really high expenses and weren't generating the revenue. So now they're trying to, having to make up for that revenue, even though they're not covering it anymore. They had a lot greater expenses than they budgeted or prepared for. So it's possible that this could level out or could possibly go down a little bit. I doubt that, but yeah, so that was a really significant cost. And I've heard that most insurance plans don't cover that anymore because of how much it was costing them versus the revenue they were generating to premiums for business and employee premiums. I'm not an expert in insurance. That's
Complex, very complex.
Or just enough to be really frustrated that the system exists the way it does.
All right, so we have, Russ has made a request or recommendation. It's an action item, so do we have a motion? Do you agree with that?
I'll move to have Russ move forward with a 3%.
Second that motion.
All right, any discussion on that motion? Seeing none, all in favor, say aye. Aye. Any opposed? Carries.
Thank you. And you'll have that's how we're gonna build the budget, and you can vote on it. So if you want to change it, you can. This is like the final one. We're gonna present this to the budget committee of the board of commissioners with. This is just so we can put together the plan.
So that's it under that item here.
Yes,
Okay.
sure.
Then we will hear from Emily, going to talk about nutrition and breastfeeding.
Yes,
Take it away.
thank you, Mr. Mayor. My name is Emily. I'm the WIC program manager, a registered dietitian by trade. And I am here just to kind of let you know what we teach in nutrition with the change in pyramid and guidelines that have come out and kind of what it means for us in our area, as well as kind of talk about what we do for breastfeeding. So next slide, please. So WIC nutrition has always been participant-centered and evidence-based. So I don't think that's going to change with the change in pyramid. I think it will be very much what the participant wants to talk about. So if they bring up a topic, that's what we educate on. It might not be about nutrition sometimes. It's sometimes, they have mental health problems and so they just want to talk about it. We try and steer them back to nutrition, but that's oftentimes, we don't get a lot of nutrition in because they're interested in something else. But we do try and get nuggets in there, little things to help them. But a lot of times it's eating on a budget, how to shop in a store that's eating real food, whole foods, shopping around the outside of the store, those types of things. Next slide. So I kind of talked a little bit about we meet parents where they're at. So if they're not interested, we don't force it. That's not what we're here for. We want to support them in whatever they want to talk about. We also use tools that they can understand. So our food list is very picture oriented so that it's easy to walk through. We've used the plate method just because it is easy for littles to understand. So we try and help the 4 and 5-year-olds understand what a serving size is, and it's easy on a plate method to teach that. I don't envision that changing a whole lot. The tool might change a little bit, but still using kind of a plate method and showing what a serving size looks like. Next slide. So this is the Academy of Nutrition and Dietetics statement on the new food pyramid and the dietary guidelines. So while many recommendations align with longstanding nutrition science and other elements raise significant concerns. So I'm not going to read the whole statement. You guys have that in front of you. But essentially there's things that they feel are fine or that they agree with and some things that cause a little concern. Next slide, please. So where the Academy sees alignment is nutrient-dense foods, including fruits, vegetables, and grains, limiting processed foods and added sugars, limiting saturated fat and prioritizing healthier fats, fiber and microbiome health, so gut health. Next slide. And where they have concerns is the emphasis on butter, beef tallow, red meat, and full-fat dairy. Guidelines do not consider individuals who cannot choose not to consume dairy products. There wasn't a whole lot of guidance on how for those that choose not to. Low-calorie, non-nutritive sweeteners. There's not a lot of evidence out there at this point for those. And then synthetic food dyes is where they have concerns. So next slide.
What is the concern about the synthetic food dyes?
Just that it's so strong. Some evidence supports eliminating food dyes and some does not. So their statement was more, there needs to be more research on that before we go out and make the bold statement not to consume food dyes.
Europe is sure leading the way in that. When we have products produced in the US that are substantially different than the very same products in Europe. That's interesting that they would have that concern. It would seem that it's relatively well established that the petrochemical dyes should go by the wayside.
Yes.
And that's from the Dietetic Association.
Yes. Yeah. Any other questions on the nutrition side that I can answer?
I did have a question on the,
Yeah,
so they align with the limited saturated fat prioritize healthier fats. And then they have a concern with the emphasis on butter, beef tallow, and red meat, full fat dairy. What fats are they?
those are saturated fats.
What?
They're modified poly unsaturated fats are the healthy fats like olive oil. That's the one. Yeah, those avocado oil.
No seed oils.
Plant-based. Yeah,
No seed oils.
yeah.
So she has a good point. So what is their opinion on the seed oils? Does Dietetic Association,
That I don't know. I did not read. But I can.
might be kind of interesting, to me anyway. I think that we're seeing pretty good evidence.
Yeah.
I am not a big fan of seed oil personally.
So do they have a general aversion to red meat or beef?
It was just the large emphasis on it and that it's at the top of the pyramid. It's also the highest cost item for, and especially within our population that we serve, the low income population for WIC. It's just a high cost item. It's not that it's not, couldn't be part of a healthy diet. It definitely can.
Mr. Chair, and they do not differentiate between the grain fed, which is the high cost and unhealthy, versus the grass fed,
Yes.
which is problematic to me. They need to differentiate between those because the grass fed is the very high omega-3,
Yes.
where the corn grain fed is not.
Yeah, I would agree.
That's, yeah, the corn is omega-6 inflammation causing.
Right.
Fatty acid, and then differentiating a lot of the research that has been out about red meat has not differentiated between the two.
Bovines are not meant to consume grains because it will lead to early liver and foot rot in those animals. Thus, that is one reason dairy cows have like a 4 to 5 year lifespan.
Hey. And then back to the non-nutritive sweeteners. They're saying that there's not ample evidence about those.
That's what I read. I would have to dig deeper on the sweeteners as well. Where their sources are coming from. Yeah.
It might be NutraSweet.
Yes.
Yes.
Okay, very good. Any other questions on that page? All right, thank you. Let's
Sure.
charge on.
Of course. All right, so with breastfeeding support, so this goes hand in hand with our nutrition support. Early start to life is important. And breastfeeding, of course, is the optimal infant feeding method. And of course, we as WIC support breastfeeding highly. We're required by law to federal regulation to not promote any sort of infant formula in our offices. We're not supposed to have bottles out. We're not supposed to have formula out that the client could see, or pictures of that they could see unless they're asking for it. So we do a lot of individual counseling with our breastfeeding moms. We do it early in pregnancy, all the way through postpartum until they're done breastfeeding. So we do a lot of telephone support. So we have peer counselors who call moms monthly or every couple of weeks as it gets close to pregnancy or to delivery, to just check on them, be that peer support and just offer any breastfeeding advice that they might want. But also to just be a friend through the experience of being pregnant. And then we also offer breastfeeding classes. Right towards the end of their pregnancy is when we try and get them into a breastfeeding class so that they have the basics of what it looks like once they deliver. We also offer a lot of materials. So we have a big breastfeeding guide that's multiple pages long that we pass out to all of our pregnant women to try and help them be as educated as possible to make this decision. So we also would provide any referrals that are outside our scope. We do train all of our staff to be breastfeeding friendly and to be able to help and answer any breastfeeding questions. But we also do have some experts on staff that can go above and beyond just basic breastfeeding questions, help with latch support, offer breastfeeding pumps, and supplies, nipple shields, all the supplies that someone might need to make it successful.
I have a question. You said there's a prohibition about like marketing formula and stuff. At what level? Where's that prohibition?
It's federal.
Okay,
For WIC, yeah.
that's good.
Mr. Chair,
Yeah.
how many lactation consultants are on the team currently?
So currently we have a CLC, so a certified lactation consultant. We have one right now.
Okay.
We have quite a few what are they? Certified breastfeeding experts. We have one that will test for the IBCLC exam, which is the international board one. She tests in April. So we'll have one of those back. We had one for a long time and then she retired.
Yeah.
So.
My wife taught this area for years. She's a nurse practitioner, so it's such an area of health and wellness for those who do one. So I'm just glad we're doing it.
Yeah.
And having fun. Good, thank you.
Yeah, of course.
And I suppose through this process, there's a fair amount of nutrition counseling for mom.
Yes.
It's, pass on what you eat.
Yeah.
Yes, definitely. We talk about her nutrition and how it would affect baby and all of that. We try and catch them as early in pregnancy as possible, so that we can get them eating healthy, so that baby is healthy when they start to breastfeed. So definitely, it's both breastfeeding education as well as nutrition education. So,
Mr. Chair and Emily, because we only are getting like half of our WIC participants to breastfeed, what do you think we can do to improve that percentage?
that's a good question. I think it's a culture thing. It's oftentimes that we have our refugees that come over and see the formula in the stores. So they think it's better than what they naturally give. So we try, it's a status thing also. So it's like, well, I can afford formula. So,
By chance have like a program that, so say they're working or they have that marketing mindset, do we have a opportunity to teach them to pump so that they can?
yes, we do. Definitely.
Interesting.
Yes, and there are those exceptions that are medically necessary for the breastfeeding is contraindicated for. So those infants will get formula. But yes, our percentage is a little low, but as you can see, if you want to move to the next slide, I have some data. So this, thanks Freddie for bringing up to the next one, segued into the next one for us. So as you can see, Idaho is in the top 20. So we're actually in the top 10 for our breastfeeding rates. So, and then if you want to go to the next slide, you'll see where we fit in all of our health districts. So, among our health district peers, it looks like we're probably 4th in infants fully breastfed. But we are pretty good at total number of breastfed. So that could be that they're partially breastfed. So they're getting both formula and milk and breast milk. So this is definitely an area where we would love to increase our rates. It's an area that we continue to educate our staff on, to educate moms a little bit more on the importance of it and what benefits come from not only to the baby, but also to her later in life. So.
I know our budget isn't huge, but I mean, the marketing for fake stuff versus the marketing of nature.
Yes.
You know, if there's not a federal, hey.
Yes.
We haven't had the fake stuff for eons.
Yes.
We had wet nurses, we had everything. And now, yeah, I mean, probably not within our health district budget per se, but you know, just a simple social media advertising, TikTok, Instagram campaign to that younger generation that's going to have children. I mean, just, I don't know, for me, it's common sense, but
Right.
you know, to be able to say, hey, these babies are healthier when they're breastfed. So
Yes.
I wish we had $1 billion to put towards making sure moms know how to breastfeed.
I
And the benefits.
So the next one is also, next slide, is just another way to visualize that same data. So the one gave you a little more data, but this is where we sit amongst our peers in Idaho. Any other questions for me? That is actually the end of my presentation.
Thank you.
Sounds like we've got opportunity.
We do.
Yes.
Well, I think that, I don't know, somehow we can come up with some out of the box ways of promoting. Increase that, what were we, 52% or something? You know, that'll pay dividends, a health perspective down the road. You know, and then along with breastfeeding, you know, natural deliveries. I mean, that's the first priming of the immune system. And we have a culture where it seems like we're promoting non-natural deliveries when all these things, when we start deviating away from the way it was designed, we generally pay a pretty good price for it. The rest has.
I was gonna say, our Stephanie, our communications manager, is here taking notes, so I think there's some good opportunities with the recommendations and suggestions with our conversation, because she helps with marketing and social media, her and her team, so. And I also just want to thank Emily for leading. She leads the largest by far clinical service team we have in our agency. So it's a big team, and we're in every county. And it's also, besides the incredible value that WIC offers, it's our #1 referral source to services like our home visiting programs, because they're seeing the exact population that we want to serve in Nurse Family Partnership, and parents as teachers. And then every couple of years, including this last year, she gets to help her team navigate the anxiety created by the lack of a federal budget set by October 1. She's done a really good job with that too, because it's tough when you're not sure if you're going to have a job, or they all care about the families they serve, and will they have the money to be able to provide the benefits that the families need. So appreciate you.
Mr. Chair, Emily, what do we do here at CDH for making it easy for our lactating mothers who are working to continue breastfeeding?
So that's a good question. So we support the Idaho Breastfeeding Coalition as well. We have several members that are on the board who have initiatives to help educate people around town of what the laws are. Here in the office, we have a breastfeeding pod out in the front. As far as CDH employees, there's pumps available to them. We have a respite room that they can reserve and pump. There's a separate refrigerator that they can store their breast milk in, recliner. And then as far as our participants that come in, there's the pod out front. They're welcome in any WIC office to breastfeed. We still have a really old recliner that they're welcome to use, but we have stools and all that equipment, and they're welcome to, and CDH employees in addition are welcome to come get support from any of our breastfeeding consultants and lactation help.
Good.
At the risk of sharing a dad joke, we need to keep milking this for all it's worth.
That's true. Yes. You got your work cut out for you.
Yes. Well, thank you.
All right,
Well, thank you.
Yeah.
Thank you.
Pass the baton.
So Emily just talked about so much of the important work that they're doing within WIC. I'm going to talk about how we've been supporting our team so that it can keep growing, we can grow participants, and just keep doing that work. So next slide. So this slide is really important to me. When I first started, almost every day, Emily was telling me somebody was resigning or quitting. I remember seeing her in the hallway and being like, what's going on? And that's reflected here that January through December of 2024, we were seeing a 50% turnover rate with our clinical assistants. We knew we needed something to do. We saw that there was low morale. The team was really struggling at the appointments. We didn't have access for appointments, and we had to do something. We did a lot of things this last year, and we've seen that really reflected in our turnover rate decreasing. The first half of 2025, we were down to 25%. The second half down to 17%. And then January through February of this year, we had no turnover. We actually had our first person resign just this week, who's up in McCall. Who's going to be having her own baby in the near future. But 1 out of 14 is we're really excited about. Next slide, please. So I want to talk about what we did. How did we get our team from 50% turnover to where we're at today? The first things we really did was we started listening. I had a lot of time with team members one-on-one. Emily and team, we set hard meetings with the team, really hearing the feedback. And they were honest. They told us things that, gosh, I know were hard to hear. And we needed to make some changes. We knew that. And we needed their input on what those might look like and how do we do that. So once we started with those listening sessions, we needed to move to a place where we could start thinking about how can we achieve our goals? How can we improve our team morale? How can we keep people? One of the things about a year ago when we were talking about budgets, we came to you all and talked about how we needed to pay our team better and be able to support them financially because that was something they were really struggling. And the increase that we were able to give last year with your board support was huge and has paid off tremendously. But in addition to that, we needed to work on the team. So the team during that session of how can we change things, they came up with so many things. We had sticky notes all over the room. We had it identified. And then we went through and we said, okay, what's going to have the highest impact and it's going to be easy to do? What's going to be hard to do? Low impact, easy to do, hard to do. And prioritized what was going to be most helpful. Emily and the leadership team and myself, we sat down and we created an action plan of what we needed to do from the team's impact. Some of those things were around our schedule. So you had ideas that some of our appointment times were way too long, and some of them were too short, causing them to really struggle with being able to complete all the work they need, being able to do that nutrition education in the right appointments. They also identified, and with Emily's thoughts of, we need to have a float, someone who's available to cover when someone calls in sick, when they're going to be out unexpectedly, to be able to take somebody when they first come in. So now we have someone who sits at the front desk with our CSRs, our other front desk support, to be able to support people, take appointments when someone's late, really be a nice support person. They identified being able to have a walk-in Wednesday. So every Wednesday, if there is someone who needs to be added to WIC, they can come right in. Our front desk lets them know that from phone calls, and we will see them that day, get them signed up for their WIC benefits. Other things that they did, we are getting close to implementing some different flexible scheduling so that we can increase our hours from earlier in the morning till later at night, which meets our team's needs as well as our participants' needs. We did some Saturday clinics and evaluating adding some more of those in the near future. And all of these things have made such an impact. The impact on the team morale is so different. The conversations with the team are so much more positive. There's less arguing among team members. They're getting along, they're working together. And it was a big lift, but I think we are so much seeing the payoff with it. And I keep looking back at Emily because, gosh, she did so much for her team, and I'm so grateful for her willingness to step in and do something different together. Other thing we changed was our onboarding process. It was very lengthy, and we were not able to even keep people through it. They were leaving before we got through 3 months, 6 months of onboarding. So now it's a more hands-on process. They're getting onboarded quicker so they can see participants faster. They're getting to see the benefit of the work that they're doing versus it just was taking too long. So all of these things were going on. We have to do, we get evaluated by the state every other year, and we were not meeting processing standards with all of this beforehand. And what a processing standard is when we need to get a person in from when they contact us for their first appointment or available first appointment. So for a pregnant woman, that's within 10 days. And for any new addition, that would be 20 days. So someone with an infant or a child. Back in December of 2024, we were at meeting that standard 84% of the time. The state expects us to meet that 95% of the time. And we were missing the mark repeatedly over and over again. Until December of this last year. Since December, we've been at 96% or better every month of meeting that standard and expectation. And it's due to all of this work, these changes that the team made, working with our front desk, identifying where there was still bumps in the road that were causing us not to meet that standard and making sure everyone had the education to know the importance of this. So now that we've done all this great work, we're really excited to see what's next. That's the next slide. So one of the things that you may have heard Russ talk about over the years has been getting the SNAP data from the state. So this last year, we entered into contracts or MOUs. We did all of the steps so that we could receive the data when it was available, but our processing standards were getting in the way. They were not going to give it to us unless we were meeting expectations. Makes sense. That was one of the benefits. So next month, we are going to get that SNAP data for the first time. And what that is participants who are on SNAP, eligible for WIC, but not currently enrolled in WIC. So they may have in the past been in WIC, but not currently. So that we'll be able to do some targeted contacts to those folks to be able to see if they want to be on WIC. And as we see gas prices going up and everything else, this is a great benefit to families so that they can save their money for some gas if they need to, that they can utilize this service with WIC. And there's so many misconceptions with WIC from I'm on SNAP and Medicaid, I'm not eligible. So we're going to be targeting to people, let them know that they are eligible. This last year, the other thing we did was look at the data, and we saw that the areas we were really lagging behind was in women who are pregnant being on WIC, as well as infants. And that's our primary people we want on WIC. We want to catch people early for all the reasons Emily talked about in the sense of nutrition support. So that's one of our main goals, is increasing participation among those goals. We're working with Stephanie and team on our marketing strategy, doing some of that in the community. We're collaborating with our health partners as well to make sure the OB and pediatrician offices that they know that it's available. They have some additional goals at St. Luke's of increasing WIC participation. So we're making sure we're collaborating with them so that within our district, we're able to do that. So that's where we're at, what we've done. I'm really excited. I think it's such an important program. And the transformation has been it's been so fun to be a part of and to support the team and getting to where we're at, where all these things that I think have been wanting to happen for a long time, we are ready to do it. We have a team that's fully staffed, almost fully trained. We're navigating new things as they come in. And I think because the team's in a better place, they're feeling supported, those changes are easier. And, that's what we want to keep doing. So any questions for me?
Do you have a sense or a ballpark on the employee longevity now? Are they average been there 6 months or a year?
It really varies. We have WIC clinical assistants that have been here as long as 29 years. And then as recent as probably about 6 weeks is our most recent person hiring. So I could get that average of everyone across the board, but we have a lot of people who've been here 5, 10 years, and then a newer set of team that's really dedicated and excited about their role.
Well, that's good. The number's going to change if we keep not having turnover. It's going to start rolling those longevity numbers up and people.
Thanks for providing them a good atmosphere. Great that the team is gelling and doing the work together.
I think this program is maybe our largest to predict the benefits in future. Absolutely.
So I just wanted to acknowledge Beth for all the work she's done when she joined the team. You can see the data and the turnover and I remember she started, I think it was November 12th. And I remember saying, well, here's your office. And the next conversation was, I want to see the WIC numbers increase. And I think that was before we showed her where the bathroom, the break room was, things like that. And there's two approaches to that. One is, okay, let's just jump forward and figure out with marketing and making calls and snap data. And the thing that I really admired is she said, we got to get our house in order first. And you can see the results of that. And that matters, right? If your team is struggling and arguing and turnover and not meeting processing standards, it doesn't matter. We could make all the calls in the world, but if we don't have the infrastructure and the team ready to see them, it won't be effective. So that was good. And the SNAP data, we want the Medicaid data too, but they want us to work with SNAP data first because it's USDA funded also. And ultimately, I'd like to get there's probably still some gaps of people who are on Medicaid, but not on SNAP. And I want to see who those individuals are and do the outreach. And we're in a really weird time too, back in November 2024, and is that WIC participation nationally and throughout the state has steadily declined for years. And it's just like, it's perplexing to me because the cost of living has gone up substantially. So kind of what's going on. So we're trying to work through that too. But if we figure a good starting point is to reach out to the individuals who are eligible and aren't participating. That'll be more effective than a billboard. You should participate in WIC. General messaging is we want to have the conversation with them and text and communication to get them at least to know, it's a voluntary program for sure, but at least they would be aware of what we can do. So thanks, Beth.
Other comment, it says a lot about you all that you looked at what you could do as opposed to looking at everybody else and saying, you need to do this, 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 and this. So you got to take a lot of credit. It's huge.
I'd like to make a comment also. This kind of ties back into the 3% contribution from the counties. I mean, the turnover going down and the reports getting done. I mean, that's good justification to me for the 3%.
Thank you.
contribution. Hey, turnover, retraining constantly is not very well. Nothing is coming.
I see this as a real opportunity to the obesity epidemic we've seen in our country, to really do something fundamentally to start out combat. Thank you.
Okay, thank you. All right. Any hands up?
Oh.
Or maybe not.
Well, Russ,
Where do you begin?
yeah, where do we begin? We did not have a meeting this week, and so I don't know if Russ has had an opportunity to follow up on some of these things we talked about last week too, and I have not. Mike Kane has weighed in heavily on every meeting we've had, which has been invaluable. How many hours have you spent down there waiting to testify?
Yeah.
Waiting to testify. A lot. Last week, one of the big bills was House Bill 808. And this was just one of those crazy things that talked about, you know, as healthcare people, we really can't advise and recommend and do the stuff that we're trained to do. And so it kind of leaves us, it just limits everything that we do. It was presented by the same person that was promoting the mosquito abatement bill. And so as far as our practitioners being able to do the things we've talked about with parental control and everything, we really haven't made any progress, have we?
That one.
I shouldn't say that. It's murky. Maybe we can get by doing what we do, but it's not defined specifically. Would you agree?
Agree.
Yeah. So that's been very frustrating. And Bill 860 with parental rights, we talked about that. That came back again and was softened a little bit. Did that get to the floor when that second version came out?
Yeah, and it's for the Parents' Rights Act that was one of the two things we wrote the letter about. There's some really good things in there. It's, you know, it's dealing like with the 988, the suicide lifeline, and individuals who were under the age of 18 calling in and then they couldn't get any support. So that's included. There's some considerations given for somebody who's pregnant and a minor. The way the law was written in 2024, when they have the baby, they can make medical decisions for the baby, but not for themselves, without getting basically authorization sent from their parents. So there's just some, as happens, right? Bills get passed and then hopefully you can do some cleanup later. It's just unfortunate 2 years have gone by. So I think that's gonna pass. It got sent to the amending order. It passed unanimously out of the House, and the lead sponsors of that are Anthony, Ehart, and Moyle. So pretty, you know, you got Speaker, you got Pro Tem, and Representative Ehart was one of the original authors of the 1329 bill in 2024. So I have hope. I mean, obviously, you never know when you're going to run out of time, but I'm hopeful, and I think we're going to be able to work with that.
Yeah,
To do
it looks better than what we thought we were confronted with
Right.
earlier.
For sure.
So, yeah. And then there's a good old Kratom issue. Anything in the last few days, is that going to die?
Spoke to some reps about that.
Did you?
Yeah. So to be seen.
Yeah, to be seen. Unfortunately,
They understand the synthetic aspect and it's just the natural one, so hoping that they will get it off the market.
right. Well, to me, and I, I'm a little outspoken, I guess, when it comes to this issue, but the other district people don't really speak up, do they? And I just think, 40% of the states have outlawed this stuff, and here we're trying to give it this shade of gray to make it okay. I mean, what in the world are we thinking?
Industry.
So industry, money over, yeah, so, anyway, hopefully, we can get rid of that. I hope so. So, and that was Bill, what, 864, I believe, is the latest version for that House Bill 864. So, go ahead, you're trying to say something.
No,
Oh,
no.
Yeah.
I just couldn't remember the bill numbers. There's been so many that.
Oh, there were.
There's a bunch of numbers.
yeah.
Yeah.
Yeah, but it just, to me, there's kind of a thrust towards taking away bit by bit what we do as public health districts. Would you have comment on that, Russ?
Yeah, I mean, I think it's just been hard to watch just because public health generally kind of worked in the background. It was the water you drink and your septic systems and food where you go buy it at the grocery store, childcare, come in to get clinical services. And I feel like the last couple of years, it's the holdover from COVID that somehow public health became not in all eyes, but, kind of the devil in some eyes. And it's been back to that defensive mode you feel like we've been in constantly, and it's how do we promote some of the policies. I know Dr. Cole and Dr. Furch, we talked briefly after the last meeting as far as how do we try to make changes and really to improve health, improve public health when we're investing all of our time trying to keep what we have. So it's been a challenge, and hopefully that'll change. I think there's always other priorities come along. It's just the first bill out of the gates of another mask bill. It's like, okay. And Conan, I do appreciate you wearing your mask when you're coughing. I get it. I think that's good. But just the whole idea of public health being some overbearing governmental organization when all we've done is we've been in business since 1971, and I'd like us to be able to continue to do that, and then explore some of the things that you all talked about that will actually improve health. So maybe that'll come in the next couple of years.
I hope so. Well, and my concern is that the pendulum, especially after COVID, doesn't swing too far so that we do not repeat some of the mistakes of history.
Right.
So, which are.
Yeah, and I think educating the public on the good things. I spoke with Capital yesterday and basically said, look, the best doctor we ever had was your plumber. Second best doctor was the one who invented, the person who invented refrigeration. And so between, all these public health measures that over eons have made us more healthy, we need to continue to emphasize the wins of public health and educate the public that, hey, look, you can go to a restaurant. Look, your septic system is safe and your sewage is safe and your water is safe because there are public health people working on it.
So we are set to meet at this time again next week. So things are winding down. And I don't know if you had any more comments, Russ.
It's fourth and long on everything right
What?
now.
What?
Fourth and long on everything in the legislature at the moment. Yeah. So a lot of things are gonna get tabled.
I think so. A lot of things are just gonna die. Yeah.
Keep trying. Keep trying.
Well,
Right. Anything else on that subject? Right. Well, back to Russ and comments on the budget plan.
Yeah, so it's kind of shared that earlier. So just that we're we will work between now and the 10th to put together a budget to present to you. That's just a couple weeks away. I know our board meeting is usually the third Friday, but this year they got moved around a bit to accommodate everyone's schedule. So it's pretty quick turnaround time. And then we have about a month to go around and present this budget along with our county data sheets, which we'll share with you at the April meeting. And Stephanie and her team work with the organization, all the managers, to put that together as far as here's what we do for Boise County and besides the numbers, but the direct impact. So we'll have that to share on the 10th. And then early next week, if you're not a county commissioner, you'll get an invite to your respective counties. So you and Dr. Cole and Dr. Young will get an invite to Ada County's meeting. And I appreciate it if you can be there, of course, Betty Ann for Elmore County, and you've always been there, and it's just nice to have the board members there. You don't have to prepare anything, but be there to help support
You have the
the
date on
process.
by chance?
For Ada County, 1 moment, please.
And I usually Corey's looking that up, I invite, especially for our rural office, like Jerry Davis is a continual guest there, because he tends to be the one that I think the commissioners, if you get calls and kind of interface with the environmental health issues,
So, April 29th, 1:30 to 2:30.
1:30 to 2:30, April 29th.
Guess with those invites on Monday.
Yeah, so then we'll have the budget committee meeting, and that will be held here. We're still going to do 10 a.m. That's when we had started the meetings as we traveled around. And this year, Boise County is going to be the chair, and that'll be Commissioner Tucker. And it'll be in this room instead of some remote location in Boise County. So, yeah,
Perfect.
yeah.
You don't have a yurt up there or something?
I'm sure we could have found something.
Oh, I have.
Alright. Okay. Well, very good. Then, we have an agenda item to move into an executive session to converse about a couple of things. So I would ask for a motion to do that under, I think there's the specific language we need
I'll
to.
move to enter an executive session for Idaho Code 742061A.
Any discussion on that? Okay, very good. Seeing none, all in favor to,
I think it takes a roll call. But
It takes a roll call.
okay,
Yeah.
well, very good.
Like, do it.
So-
Or if you want to do it, I could.
Well, yeah, go ahead and read them off.
Oh, yeah, Dr. Ding Young, Ada County.
Aye.
Commissioner Krista Rogers, Elmore County.
Aye.
Commissioner Clay Tucker, Boise County.
Aye.
Dr. Ryan Cole, Ada County.
Aye.
Commissioner Pat Caldwell, Valley County.
Aye.
Betty Ann Nettleton, Elmore County.
Aye.
And Chair Dr. Greg Perch, Ada County.
Aye.
Okay, the board in executive session at 9:53 a.m. Dustin will give us the go-ahead as well.
It is 10:41 and we're coming out of executive session with no action taken. And we are moving on to the next agenda item, which is our discussion about health topics, open discussion. Now, this month I didn't get a chance to send anything out in particular, but I'll open it up and maybe make note of this in the future, that if anybody does run across anything, certainly let us know, and we can have a discussion on it. I did just find a couple of things this week. The CDC finds, in this article or publication with the CDC, they found a record high obesity rates for children. And that goes up to, I think in this study, they used up to the year 2023. The data was for 2023. And so we were talking about, formula and things like that. I know I've mentioned this story before, but in Health and Welfare Committee hearing, we had a conversation about what was portrayed as a non-allergenic baking formula. And the first ingredient was high fructose corn solids at 55%. And then the third ingredient was omega-6 fatty acid safflower oil, inflammation causing. And that was portrayed as healthy. And that's why I like the breastfeeding conversation and the nutrition conversation. If we're having formula that's refined sugar from the very moment kids are born, and addicting them to refined sugars at that earliest of ages, I think those, activity levels and things are part of what leads to headlines like this. And so the things we do in the district to navigate or promote healthy eating, healthy nutrition, fitness, etc., will mitigate a lot of that. So that was published February 26th. So that was relatively new conversation that we're still in the country, struggling with childhood obesity, and in fact, setting record obesity rates. And, we talked about food colorings and non-nutritious foods and things. This was published in a cardiology journal just a couple of days ago. And surprisingly, they found an association between ultra-processed food and cardiovascular disease. And I suspect that's not shocking to anybody, but when we're having conversations about, what foods or things might be on WIC lists and just general conversations about public health, it's pretty well established that the direction that the administration or Federal Health and Human Services and the Department of Ag are going seems to be supported in, current research. Again, this one was published just a couple of days ago in that cardiology journal. So surprising, synthetic food isn't good for us.
Shocking.
But yet, the lobby for those is pretty strong. And those are some headwinds that are difficult, but nonetheless, if we're going to be an organization about health, being mindful and, possibly changing up the thought process, generally what we have been doing, I mean, not the health district, but generally in the country, it's healthcare thought process hasn't produced particularly strong fruit if we're having record numbers of chronic diseases and record childhood obesity, diabetes is the or adolescents are the fastest growing population of type 2 diabetics. Maybe it is time to change things up and challenge the nutritional narratives and, even associations and organizations that purport to be health oriented find themselves on the backside of research. I don't know. That's a couple of tidbits that I found this week.
Follow the subsidies.
Follow the
Subsidies.
Yeah, I mean, to that point, I won't give a lecture on this now because it's a beautiful day and we accomplish what we want, but down the road, if you want me to give a 5-minute presentation on glyphosate, what most Americans don't know is glyphosate was patented by Monsanto in the early 2000s as well as 2010 as a broad spectrum antibiotic antimicrobial. 80% of adult Americans have glyphosate in their urine. 7% of American children have glyphosate in their urine. It is wiping out the good microbiome in our guts. It's causing fatty liver. It's causing endocrine disruption. So it's not just processed foods. It's the chemicals, i.e. every American just about getting an antibiotic in their daily food without informed consent. That adds to the biological processes. And it's hard to avoid, but it's ubiquitous in our environment. And then one more thing that adds to that endocrine and obesity epidemic, as well as so many other metabolic processes in the human body. And of course, we have an executive order protecting it at the moment, right? And that's a disaster for human health. But again, if you want me to give a 5-10 minute presentation another day, I would be happy to do that.
Well, in microbiome, I mean, that was one of the line items on one of her slides is fiber and microbiome health. And
yeah, and you have good microbiome, and then you eat food, and you're literally eating healthy food. And you have an antibiotic, and it killing your healthy microbiome. It's dog chasing its tail.
And the microbiome is so important for good health, brain function.
70 to 80% of your immune system is trained in your gut.
One of the highest exposure rates for glyphosate is the urban landscaper in his yard.
Golf courses are the worst. And then the urban landscaper, you are correct.
I know it's a massive shift to try to move, influence, turn, whatever, but I think about the National Association of Local Boards of Health. So that really is the lobbying arm of the 3,000 health departments. So, and Becky and Jane have been around long enough to know it went through some rough times as far as I think it basically self-destructed. They're back. It's an organization. I'm just thinking about the conversations we're having, and Dr. Perch, like you mentioned, these are bigger issues than Central District Health, but it's not bigger than local boards of health, and having that connection to the National Association and being able to bring these ideas to them and say, you'd have to get buy-in from other board members like in Idaho, but the influence you could have at the federal level, I think that would be at least one good avenue to bring like resolutions for the same ideas that we do here locally. I get it, agree, but it's just like, what do we do here? I think what we do is you all get more involved. And those meetings have traditionally been in August, and we have the budget, send you, pay for your travel and all that at registration if you would like to go. And that might be something to think about too, as we're working on resolutions for the Idaho Association of Local Boards of Health. We tend to deal with Idaho specific issues, not the bigger issues. And that might be something for this fall's meeting, like in October, to possibly bring some proposals to push to the national level. And again, they're going to happen overnight. Of course, not at all, but I think the voices and the sort of that, like voices of reason, this isn't working, as you pointed out. And when you have the data to back it and the ability to articulate what could help, I think I just offer that up. That's a good avenue and something that Central District Health would support for all of you.
really agree with that, Russ, because we dropped that membership,
Yeah,
2 years ago. I felt it was a mistake. I was not in favor of it, but
yeah,
to go and get the education and to interact with the players
yeah,
that are there is huge.
yeah.
I do have to say, I tried to go one year and one of their requirements was to be
I
vaccinated
remember.
and I couldn't go
Yeah,
because I'm not vaccinated or COVID vaccinated. And so that might be something,
I
I
would,
don't know if that's still a requirement. That was several years.
that it would be.
But we had already gotten the travel plans and everything. And
Yeah.
I looked and went, oh, well, I'm not going to get that to go.
I remember talking.
And I never ran into that.
And maybe it was the timing. I don't know if it's still a requirement, but that's something for everybody to think about. So I wasn't able to go.
But I think that's a missing piece on that,
It was like,
influence of our board and how we want to move forward on some of these issues.
Yeah. And I think the local level stuff too is just like you said, you're down there talking to the legislature and, the support would come from the agency and from the staff and be able to put together, talking points, whatever you could do, or make the phone calls to legislators in your area. And I think it does matter, even something as simple as sending an email saying, I think this is bad public health policy, this is why, or this is good public health policy, and this is why. And to your point, we have these calls and you're one of the few that are, the chair has been there this year, not so much last year, lead meetings, but I'm talking about the executive council meetings. And you gotta have them. That's the way to get your voices heard locally and then now nationally. And I just think it's so important that if we're gonna get anything to change, somebody has to speak up and say, this isn't okay. And as was pointed out, there's a lot of money influencing the decisions that are driving bad health in our country, no doubt about it.
Everybody else is having the same problems that we are, and if we can collaborate, that's a big deal.
Yeah, a lot stronger voice.
Last month I included a link to a video. Did anybody find the time to explore that?
I watched it.
Yeah, I've seen it.
No, the rest watched it. I shared that with him.
National questions. Again, to Betty Ann's point, bringing it to the national level, and to Russ's point, I think the idea.
You might look at that this next month, and it's really enlightening, and and I'm open as always to actual scientific commentary and challenge and the scientific model is supposed to be about critique and challenge and not just hyperbole and accusation. But yeah, that might be something for next month to visit. Anybody have anything else?
One thing that I like to see getting increasing attention is the effect of brain development and screen time in our little ones.
Yeah.
That's a big one. And, we're talking about these mental health issues. Well, wow, are we ever growing up? We are.
Well, most people, again, this is a different lecture, but the blue light from the screen literally causes neurodegenerative changes through certain biochemical pathways. So chronic blue light exposure is neurotoxic. It's literally the children using a visual toxin, not from the input that's there, but the light that's there.
Well, and they're finding now, even in the educational process, they thought that these were going to be great adjuncts to learning. And I've seen a couple of references to studies that show it's actually making scholastic learning less efficient or less productive. And districts are going away from electronics and back to whiteboards and chalkboards and handwriting and that sort of thing. But yes, the physiologic issues of the screens and then the academic and the brain function learning aspects of it are not, are showing to be dangerous, if you will. Well, unless anybody wants to filibuster for 4 minutes. Adjourned.
Our next meeting is only what, 3 weeks away?
Thanks. Have a great week.